doctora Mónica Martina, enlace médico en México para el Cook Children's Hospital Pediátrico. Agradecemos al doctor Benavides su amable invitación a participar en esta sesión mensual. De parte de la Sociedad Mexicana de Neurología Pediátrica y el Cook Children's, agradecemos su presencia esta noche. Tengo el gusto de presentar a ustedes al doctor Warren Marks, neurólogo pediatra y director del programa de desórdenes del movimiento y neurorehabilitación en el Cook Children's Hospital Pediátrico. También es profesor emérito de nuestra institución. El día de hoy hablará de trastornos del movimiento en pediatría. Al finalizar la ponencia habrá un espacio para preguntas y respuestas como siempre. Gracias de nuevo y comenzamos la presentación, por favor.
Welcome. I'm Dr. Warren Marks. I am the Director of Rehabilitation and Movement Disorders at Cook Children's Medical Center in Fort Worth. And today we're going to spend a little time talking about a general approach to the treatment of movement disorders in children. So what I'd like to do is share with you an approach to movement disorders and how to think about them, and what you should be looking at when you're seeing a patient in the office. Beginning with the obvious of taking a detailed history, a family history, a medical history, and then beginning to recognize the different patterns and age-specific patterns of what's normal and what's not normal. Because at certain ages, some patterns of movement are abnormal and some are normal, as you well know. And then we're going to define what is the dominant movement disorder in the child you're seeing, and look for other evidence of neurologic dysfunction, other movement disorders, talk about diagnostic workup, and I'm going to show you some examples of some movement disorders to give you some sense of what we're talking about. And I suspect that most of you in the room will be familiar with most of this. So movement itself requires an organized firing pattern between neurons. And that the way they communicate movement is by changing the pattern, the frequency, and whether the excitatory or inhibitory neurons are the ones that are firing. And when we have abnormal movements, it's due to an imbalance between those positive and negative actions that we need for nice, smooth movement. So in order to characterize movements, I've developed some ways of thinking about them, and we need to think about both the phenotype, and now we need to really know about the genotype, because that's what drives treatment. So from the phenotypic perspective, or what the movement looks like, the questions are, is it a hyperkinetic and overactive movement, or a hypokinetic or underactive movement? And if it's hyperkinetic, is it a fast movement or a slow movement? Is it a pattern movement? Is it random? Does it occur spontaneously? Is it triggered by something? Is it there all the time, or does it come and go? Is it paroxysmal? And what is the patient like at rest? Is their tone normal? Is it increased? Is it decreased? And movements either voluntary or by abstraction. And then from the genotypic standpoint, we're going to think about whether this is truly an identifiable genetic disorder, because what we can identify today and what we can identify next month may change. Or is this a non-genetic disorder from a structural injury? And even there may be genetic factors. As we are now learning, children with CP who have structural injury also have a significant increase in copy number variations and things that may alter the genotypic makeup and tendency to have certain movements. So what are the abnormal movements that we're going to focus on? And this is probably going to be a lot to cover, and we're going to have to do a little bit of fast talking. But we're going to go through ataxia and athetosis. We'll see some chorea. We're going to spend a little more time talking about dystonia and myoclonus, tics and tremors, and then we'll see examples of most of these things. And you'll notice I've thrown in myotonia, which most people don't consider a movement disorder, but it does affect your tone, and so it often shows up in a movement clinic, and I think we should at least recognize that. So let's start with something really simple. Let's start with tics, because I think everybody has probably seen children with tics, because they're quite common.
So is that the one that's the most troublesome to you?
Yeah. I'm always that right there. When I was like all the time.
So you can see
Does
that's a
that interfere with school?
Mm, No.
No.
Testing in the library. Yeah, but I've been doing good so far.
So it's interesting that he says it doesn't affect school, when it's hard to imagine how that's not certainly socially impacting him in school. Here's another youngster with tics. Now I will tell you that when you watch him, you're probably gonna have the same thought I did. Are these really all tics, or is some of this voluntary? And that can be tricky to tease out, but there's a good chance that some of this was under voluntary control, and that greatly impacts the decisions about treatment, because they were seriously interested in really invasive treatment like deep brain stimulation, and we really had to kind of come back off the ledge and decide that wasn't appropriate. And as he's grown older, it's turned out that that's really would not have been a very good thing to do to him. So Tourette syndrome, as you know, is marked by a changing repertoire of tics, both motor and vocal, typically present for greater than a year. And they often have comorbidities of attentional problems, obsessive compulsive disorder, anxiety, depression, learning disabilities. It's generally not thought to be truly genetic, although there are clearly familial tendencies. Perhaps one good exception to that is in Fragile X. There seems to be some increase in the frequency of tics and Tourette-like syndromes. Now, that's in comparison to stereotypies, which are repetitive, simple movements that often can be voluntarily suppressed for a while, similar to tics. And they have been described by Dr. Harvey Singer as purposeful but purposeless, meaning they probably do something for the individual patient or person, maybe calming, things like that, but they don't really serve any functional purpose. They are primarily, but not exclusively, seen in children with developmental disabilities, and in particular autism, or some syndromes such as Angelman syndrome, and they may even be medication induced. Tics are typically onset around 4 years or older, and they often have an urge or a warning before they get their movement. They are more commonly seen in normally developing children, and they typically wax and wane, and many of them fade away over time. As opposed to stereotypies, which usually start in younger children, they have no aura, and about 85% of them are seen in children who have some type of developmental disability, and in particular autism. They typically do not resolve over time, and they typically stay with you even into adulthood. Even when they occur in the context of a developmentally normal child, you can see them well into adulthood.
Not at all.
Now, here's a good example of sometimes when our cure is maybe worse than the treatment. So here's a youngster who had tics
control these
and
movements at the
ADD.
Not at all.
And was put on dope block around 4 years of age. That was really quite refractory to therapy, and very difficult to manage. When I saw him, he had been in the emergency room every day for the last 2.5 weeks. When he came to us, we gave him a trial of a few medications to see if we could calm it down. It did not work, and he ultimately had deep brain stimulation put in, which has been shown to be very effective for adults with tardive dyskinesia. Now, the role of DBS and tics is still evolving, or tics and Tourette's, in Tourette's is still evolving. There's an ongoing registry and study of the effects of deep brain stimulation in Tourette's that's housed out of the University of Florida, and I expect that we will have some information coming from them in the next year or so. But you can see that DBS was really very effective at controlling his abnormal movements. Okay, so ataxia. Everybody's pretty familiar with ataxia, okay? I'm just going to show you some examples of this girl trying different things. So this is her ataxic gait. It's not pure ataxia. She clearly has some dystonia along with it, and a quite striking tremor, but she is very independent. This was not a genetic disorder. This was induced following a traumatic brain injury from a car accident.
Okay, concentrate. No, put them up, baby. Put 'em up.
Okay, top, this is another young lady with ataxia, and you can see how hard it is to perform difficult tasks. She was simply trying to paint her fingernails, and you can see her accuracy was not very good. So what causes ataxia? Well, we typically think of this as either a cerebellar disorder or a sensory disorder coming from the posterior columns of the spinal cord. And the most common sensory ataxias are either Friedreich's ataxia as a genetic disorder or metabolic deficiencies in B12 or B1, which is thiamine, and they can be chemotherapy induced. For cerebellar causes, clearly they can be structural, they can be inflammatory, and now with the sort of explosion of autoimmune disorders, we're seeing lots more children presenting with ataxia due to autoimmune encephalitis patterns, and they can be inherited. You can have inherited cerebellar underdevelopment syndromes like X-linked cerebellar hypoplasia and things like that to think about. So for ataxias, these are some of the inherited ones that we think about. The Friedreich's ataxia and these which are autosomal dominant. There are autosomal recessive ataxias, including ataxia telangiectasia. Some of the brain iron disorders may present with ataxia, and then there are the pontocerebellar hypoplasia syndromes. And then there are some X-linked disorders, such as X-linked cerebellar hypoplasia that I alluded to, the deafness dystonia syndromes, of which there are several that have hearing loss dystonia and ataxia. And there are some mitochondrial disorders that can mimic some of the others. The most striking one that I've seen is the NUBPL mitochondrial disorder, which presented like a early onset ataxia telangiectasia. So how do I evaluate ataxia? What I think about is what's treatable first, and I can worry about everything else later. So I think about treatable disorders, and I think about the comorbid findings of deafness, dystonia, cognition, and then things that are not neural findings that may be involved, like cardiomyopathy and endocrine disturbances that you may often see in things like Friedreich's ataxia. So my general approach for ataxia is to begin with an MRI, looking for structural lesions, looking for atrophy, and looking for evidence of mineral accumulation. Because you always have to think about brain iron. And I always, in my mind, have Wilson's disease because it can look like almost anything and present at almost any time. Think about vitamin E deficiency, probably the most easily treatable of the ataxias. Screening for ataxia with either FP and or CEA, and then immunoglobulins. I think about carbohydrate transferrin disorders, the CDG disorder. Ataxia is the most common presenting symptoms. They can be multi-system. They have lots of symptoms that can be treated, and they're often under-recognized, and it's a very inexpensive and easy test to do. One little key is if the lab that you're ordering your CDG testing from is not familiar with it, and they primarily do adults, they're going to do the wrong test. They will do the carbohydrate transference that they do in adults, which they use to look at, they use it to look for alcohol abuse. So that is not the correct test and will not give you any useful information in most of your children. And then at least do lactate screening to think about the mitochondrial disorders. So there are medical treatments for ataxias. Most of them are not truly very effective. I am a big proponent of amantadine. I think it has been helpful. You can also use some of the newer variants of that they use in Alzheimer's, like nimandine. But I generally will at least try amantadine with some success. Okay. When those things don't work, I'll just show you a quick picture. This is a young lady. So this is the one you saw earlier. The medications were not very effective at all, but this is her following deep brain stimulation, which was put in primarily for her dystonia, but you can see it has a pretty striking effect on her ataxia. And I think in a minute here, you're going to see her stop, and she actually developed the point she could actually do pirouettes. So let's shift gears a little bit and talk about tremor. This is a typical tremor pattern of him trying to trace the spiral, and you can see really having trouble making a straight line. Tremor is relatively common in children. Most of the time, it is not a malignant disorder early in childhood. It could be a benign essential tremor, but you always have to think about the really serious treatable disorders, the most common or the most serious of which would be Wilson's disease to think about. And here you can see an example of a Kaiser-Fleischer ring. So children with tremor, I generally screen with thyroid, copper, ceruloplasmin, and consider an MRI scan, although I don't always scan them. And then think more about treatment and whether the tremor is enough to warrant treatment. None of the treatments for tremor are tremendously effective in young children. Propranolol or beta blockers or atenolol, if they have asthma, is usually my first choice. I will try gabapentin and topiramate. Primidone, to me, which is mycilene, is a last resort just due to the cognitive impairment. If it's a dystonic tremor, then you can use trihexyphenidyl in small doses. And again, deep brain stimulation has an approval for tremor in the United States without an age restriction, which is a little different than it is for dystonia. We have only done, in our center where we've done 150 DBSs, we've only done 2 or 3 for tremor over the years. So what about chorea? Chorea is, again, fast movements. They're jerky, they're irregular, unsustained, they're not particularly rhythmic. They just seem to move from one part of the body to another. This is a child who has, I think it was post-cardiac pump chorea. No, not this one. That's a different one. Sorry. This was an encephalitis-triggered chorea. It's often seen in the context of other disorders such as the autoimmune disorders. It's been seen with varicella. You can see it following cardiac bypass surgery. There are hereditary choreas, and treatment is fairly difficult. So from the genetic standpoint, you can have benign hereditary chorea. Paroxysmal dystonias can have chorea associated with them. Obviously, Huntington's in older children and adults. Huntington's in children does not present with chorea. It typically presents in a Parkinsonian fashion. The brain iron disorders and have these inflammatory, the most common of which is clearly Sydenham's chorea, which is a post-streptococcal disorder. Hypoxic injury, toxic metabolic, and the autoimmune encephalitides can all cause it. From the treatment standpoint, many people like to use valproate. I personally prefer to use oxcarbazepine as a starting place, and most of the time I have found it to be successful. I would then think about valproate, amantadine, and then beta blockers, or dopa blockers or dopamine depleters. I really reserve those not as first choice, just because I really think they have much more in the way of potential side effects, especially in the young children where they are likely to be on this for a while. Treatment is not necessarily lifelong for these acquired ones because they may resolve over time. And so you always need to be thinking about when you're going to begin to taper your medicines. Okay, let's shift to myoclonus. Myoclonus are sudden, really quick, jerky movements. It can be isolated to one extremity. It can be sequential, moving from one extremity to another, or it can be kind of random, one extremity, then another place. It can be patterned. It can be random, frequent, infrequent. Most importantly, it can be epileptiform or non-epileptiform, and that's really important to sort out. And it can be benign or malignant, meaning there are some benign myoclonus syndromes, but clearly there are some progressive myoclonic disorders that are quite problematic. Treatment is primarily with anti-convulsant medications, the anti-seizure medicines. My starting place is generally zonisamide, and that was really based on some data from myoclonus dystonia showing that it can be very effective. And it actually turns out that I find it to be very useful in most of the myoclonic disorders as a good starting place, and it's generally well tolerated. So when myoclonus doesn't respond to medications, then deep brain stimulation in the context of myoclonus and dystonia can be very helpful. So this is not a genetic myoclonus dystonia, but they respond in a very similar fashion. This is a young man who had post-traumatic myoclonus dystonia, and he had some hemibolismus that goes with it.
Take your two index fingers and point them together.
So you're going to see here in a minute when he's trying to do things that the right arm is really going to start. Now this is a big problem when your life's goal is to be a welder. Okay, so he was tried on a number of medications with no. I'm going to see if I can't rotate. Okay, I apologize. This slide, no matter how many times I rotate this picture, it won't stay rotated. So, but you're gonna be able to see the arms and how different they are. So this is after deep brain stimulation, and he has virtually total control. He can't be a welder, which is what he wanted to do because of the limits of DBS, but he is a diesel mechanic. So he's been able to get on with his life very effectively. Now I'm going to briefly digress and talk about myotonic disorders. And actually that slide's out. I'll come back to that slide in a minute because it got out of order. Movement and tone are what we're going to talk about next. So they are not the same thing, but they are definitely interrelated. So tone is the resting tension on your muscle. It is not strength. You can have normal strength and decreased tone. And movement disorders are most commonly associated with either normal tone or increased tone, not so much with decreased tone. So myotonia is a prolonged contraction of a muscle that you can see when the muscle is stimulated. It can be exacerbated by cold, stress, sometimes exercise, and I'm going to show you what myotonia looks like. So this is percussion myotonia. So you're going to see, I'm going to thump it, you're going to see that muscles, it's just going to get stuck and it won't relax. Okay, you'll notice his hand is wet. That's because I put it in ice water to help stimulate the myotonia.
Okay.
What they often present as is muscle stiffness. So this is a young man who, when he first gets up, he's really stiff, and you can see he has trouble walking and running. But as he's getting warm, he's getting, see his picking up, he's getting less stiff. And that's pretty typical for myotonia. Okay, so I'm not going to worry about going through myotonia's differential because we're really focusing on tone and movement. But I just wanted you to keep that in mind, that you should at least keep the myotonic disorders in your mind when you're seeing movement, because I can't tell you, it's not often, but people get referred for hypertonia, and it turns out what they really, or dystonia, and it turns out what they really have is myotonia. So even as a movement person, you should be able to recognize the presence of myotonia and begin to change your thought process. Okay, so tone can be characterized as normal, abnormal, obviously, and things that are normal at one age, like an infant with an ATNR, are not normal when you're 12 years old and you have dystonia and you see these primitive patterns come back. So when you see a child who's hypertonic, it's important to sort out whether the hypertonia is from spasticity or dystonia. 10 years ago, it made a lot less difference because we didn't have many good treatments for either. Now it really does matter quite a bit because the treatments are quite different, and treatments for some do not work for the other. So spasticity is velocity-dependent resistance to movement. It's usually in a single direction and usually associated with upper motor neuron signs such as hyperreflexia. Dystonia, on the other hand, is not really velocity-dependent. In fact, it may be worse the slower you try and move the extremity. It is usually in multiple directions, and the reflexes can be normal, decreased, or increased, depending. If they're very dystonic, you're not going to get reflexes because they'll be to the point of almost rigidity. So the hypertonia assessment tool developed by John Mink and others is a very useful way of sorting through whether you have dystonia or spasticity or rigidity or some mixture of both. So there are just 7 points on the scale, and you look at each point and say yes or no. If it's a yes, then you get credit for whatever the movement is that you're looking, or the tone is that you're looking at. So for the first one, increased voluntary movements or increased involuntary movements with postures or touching of another body part, that's indicative dystonia. So that would be a yes if it's there, and you put that there. And so you could have dystonia, spasticity, or rigidity. There's three points for the dystonia, 2 for spasticity, and 1 for the rigidity. And you can do it in each individual extremity. We use this a lot in our clinic and in our motion lab to help sort out which movement it is we're looking at as we're studying their gait. So dystonia can be extremely disabling. It's marked by sustained or intermittent muscle contractions that cause abnormal and often repetitive patterned movements or postures. The movements are sequential. They're often pattern firing of antagonists and agonists, so that you get a flexion and an extension, a flexion and extension. If you truly have true absolute co-contraction, you really have rigidity because everything's firing at the same time. So this is really patterned sequential firing. The way we classify dystonia is based on the clinical characteristics and then the etiology. Based on age of onset, pattern of distribution, whether it's generalized or local, what happens to it over time? Does it get worse? Does it stay the same? Is it progressive? Is it paroxysmal? Is it there all the time, or is it triggered by something? And what are the associated features, both movement and non-movement, as we talked about earlier? And then we can look for etiology in terms of pathology, inheritance, acquired conditions, and genetics. Okay, so the genetics of dystonia are quite extensive and really are a talk into themselves. So I'm going to talk just a little bit about treatment for dystonia, and I'll give you the reference for all these tables at the end. But most people agree that as a general rule, a trial of levodopa or levodopa carbidopa is worthwhile in almost all dystonias, because many times they'll respond even if we don't have a good understanding of what's triggering the dystonia. Beyond that, the drug kind of the mainstay. Baclofen can be useful for dystonia because of the doses that are required. For specific triggered paroxysmal dystonias, acetazolamide or carbamazepine can be very useful as well. So there are a lot of things to think about depending on your diagnosis. Okay, so here we see one paradigm using the combination of levodopa and a carbidopa as actually a diagnostic therapeutic trial, so that if it's effective, you can begin to go down one pathway, and if it's not effective, you can go down the other pathway, looking for causes and then potential treatments. So speaking of genetic dystonias, okay, so this is a young man with DYT1 dystonia. This is the most common of the genetic dystonias, the first described. It's a defect in the TOR1 protein, typically limb onset around age 5 to 10, somewhere in that range, and then begins to spread. Usually starts on one side and then begins to spread. This young man's actually right-handed, but you can see now that his left hand is his more functional side. And you can see for him, it really involves the upper extremities more than the lower extremities. His mom also has DYT1 dystonia. That was a big help in getting to his diagnosis quickly. He failed medications and ended up with deep brain stimulation. DYT1 is kind of the poster child for DBS, but here you can see that right hand that was so dysfunctional earlier. And this is him after his DBS put in. You can see how functional the right hand has become. He has now gone on to graduate college and move on with his life. So there's a special group of disorders that I want to mention, which are the genetic syndromes with movement disorders and epilepsy. This makes for a really complex management because you have dystonias and myoclonus and ataxia, and you also have convulsions of varying types, including myoclonic and generalized epilepsy, as well as partial epilepsies. This really highlights the fact that dystonia is a movement disorder driven primarily by subcortical neurons, whereas epileptic movements we generally consider to be movements driven by cortical origin. And even that's now come into question due to this group of disorders. At the end of the, some of the disorders that are included in this are the GNAL1, the GNAL, the pontocerebellar hypoplasias. There are a whole variety of these disorders, and both their epilepsy and their movement tend to be quite difficult to treat. One thing that actually can mimic these is the autoimmune encephalitis disorders, particularly NMDA, because it can have the combination of epilepsy and movement disorders, and you can see a host of movement disorders and a host of epilepsies in these acquired syndromes. So that is actually adding to our understanding, perhaps, of the role of glutamate as one of the central drivers in these disorders. I want to briefly mention that in the context of identifiable genetic or non-genetic movement disorders where we can clearly identify a cause, you can also have disorders where the cause is less clear and not really identifiable. What we have come to call the functional neurologic syndromes, or in old terminology, conversion disorders. These are not really purely psychiatric disorders. They can in fact occur in the context of other movement disorders and other medical conditions in general. But what you have are movements which are out of proportion to the actual physical findings and physical exam. They're relatively common. They've been thought to represent anywhere from 5 to 20% of visits to a pediatric neurologist. The frequency range is really highly variable, ranging from 1 in 100,000, which is undoubtedly an underestimate, to 9 out of 1,000, which is probably closer to the real number. They're really not that uncommon. The most common are clearly pseudo-seizures and gait disturbances. They tend to be somewhat more common in females. They are a little more common. They are more common in adolescents, but they can be seen in children of really any age, even down to very young children, which is really good information showing that they're really not specifically psychiatric disorders, and there may not be a specific identifiable stressor. And again, they often occur as a comorbidity in the context of other disorders. So in summary, back to this original slide, most of your information is going to come from your family and medical history. It's important that you recognize patterns that may be age specific and recognize the differences in tone and movement so that you can define the dominant movement disorder. it's very helpful to identify associated symptoms because that will help you narrow down your search for what your cause is. Same thing with non-organic features, looking for organomegaly, skin changes, eye changes that may point you in the direction of a specific disorder. That will help you tailor your diagnostic workup in terms of imaging, biochemical and lab screening, and then genetics. And that will hopefully then allow you to devise a more specific treatment plan. Movement disorders are highly complex. There is often overlap with multiple movement disorders, which can really compound treatment. They can also be seen in the context of neuromuscular disorders, such as myotonia and epilepsy, in particular with cerebral palsy, and in the context of the GSMDEs, or the genetic syndromes with movement disorders and epilepsy. The characterization and classification are critically important to determine what you're going to do for treatment, as there's an expanding array of treatment options, including medical and surgical options, which I've just barely touched on. I'm providing for you some references. So the first one is a really basic, good description of movement disorders in general. The charts that you saw mostly came out of this article, lead author by Dr. Coy, that a group of us got together on developing for just a general approach to movement disorders in children. And then the third is a recent review of the use of neuromodulation in childhood onset dystonia, from one of the PM&R journals. So now with that, I will stop, and that should allow some good time for questions.
Al Dr. Marks por su ponencia, espero que la hayan disfrutado todos. Los invitamos a enviar las preguntas que tengan y vamos a empezar la sesión de preguntas y respuestas. Acompañando al Dr. Marks se encuentra la doctora Stephanie Acord. Ella es neuróloga pediatra, también del Cook Children's Hospital Pediátrico, y es mano derecha del doctor en el programa de desórdenes del movimiento. Entonces vamos a empezar las preguntas. Pregunta la doctora Camacho de Sinaloa: ¿habrá alguna relación entre el manejo de anticonceptivos orales con trastornos del movimiento?
I don't know if Dr. Marks, if you want to do this at all. I don't know of any association necessarily with oral contraceptive medications. And are they asking about the onset of movement disorders or whether or not it can be associated with it?
La doctora pregunta porque tiene una paciente adolescente que comenzó con tics cuando empezó con anticonceptivos orales.
Tics? Well, tics in general become more frequent during the pre-puberty/puberty period. So it's potentially more kind of associated in terms of context or from context that it's more coincidental, probably would be my guess, than actually related to the medication itself.
Perfecto. Tenemos aquí otra pregunta de tics. Pregunta el doctor Ocaña de Coahuila: ¿cuál es el tratamiento para tics refractarios a medicamento?
You want me to take this, Dr. Marks?
You want to, or you want me to talk about DBS and tick and Tourette?
You can if you want.
Okay, so most ticks will respond to medications and or behavioral interventions, which are clearly our first choices for how to treat. In fact, we prefer to go behavioral first, medication second. In the case where tics do not respond, where Tourette's does not respond to medication, in older adolescents and young adults, deep brain stimulation has been used. The current tick Tourette DBS registry has probably about 200 to 250 patients in it. We have actually not done DBS for Tourette's. In my mind, they really need to be older adolescents because so many children's tics will improve as they get older. The targets have been GPI and actually several targets in the thalamus, all of which seem to have some benefit, but there's no clear choice and there's no current actual approval for DBS in Tourette's, at least in the United States.
Ok, gracias. Doctor Marks o doctor Acord, ¿podrían hablarnos un poquito de qué es DBS? ¿Cómo es el procedimiento y cómo lo manejan en su hospital?
So DBS is deep brain stimulation, and Cook Children's is one of the largest from a pediatric standpoint of performing deep brain stimulation surgeries in the pediatric population. The program started, what, Dr. Marks, 11 years ago?
2007.
2007. And we operate under the a company called Medtronic with a humanitarian device exemption. So we've done probably well over 130 different patients, if not potentially a little bit more, for DBS. Essentially, we do it for several different things. Most of the time it's for hyperkinetic movement disorders. It's deep brain stimulation in the adult population, people know mostly related to Parkinson's disease. But in the pediatric population, we use it for things like dystonia. Sometimes we use it for ataxia, for tremors. Again, sometimes they're starting to use it for Tourette's. There are some indications for people using it for epilepsy. And depending on what the actual symptom from a movement disorder standpoint that you're trying to alleviate is where you actually target within the brain. So a lot of times we'll target the GPI or globus pallidus interna from a dystonia standpoint. And we've more recently started doing kind of what we call temporary placement, where we are looking at surgery where we implant usually several more electrodes than we plan to implant permanently, to try and determine is there a particular area of the brain that seems to respond a little bit better. After the initial surgery, usually it's a 2-stage surgery. We do with an intraoperative MRI machine these days. When the program first started, it was when the patients were awake, but now it is while they're asleep. So we use this high-tech MRI machine to help us with localizing kind of exactly where we want to go within the brain. And then our neurosurgeon actually places the electrodes into the brain. The second stage is going to be the implantation of the generator, which usually kind of goes on the chest, which is where the kind of memory and battery is going to be to help with the programming of that device. And so usually a couple weeks after the surgery, they usually come back to the office and we start the programming of it to kind of, there's 3 different parameters that you can adjust. And depending on how they respond is usually kind of what we kind of make adjustments in. And then in addition to that, there's certain parts of the brain that seem to respond to different parameters better than others.
The surgeries themselves now have become very streamlined. The placement of the leads involves simply an overnight stay in the hospital. The generator is put in several days later, and our patients now may or may not even stay in the hospital overnight. Oftentimes, if we do it in the morning, they'll just go home in the afternoon and then come back later for programming. We do manage lots of patients that are far away. It is a bit of a logistical challenge. It is helpful to have somebody at the other end who can at least manage emergencies with the DBS, like having trouble charging and things like that. But by and large, Once we can get things set and stabilized, it is a technology that can travel with the patient pretty effectively. I don't know if that answered their question or not. Okay, Monica, we can't hear you. You're muted.
Perdón a todos. Sí, doctor, muchas gracias. Pregunta el doctor Dávila de Ciudad de México si tienen experiencia en síndrome de Tourette con cannabidiol o inmunoglobulina intravenosa.
So I would say from the immunoglobulin standpoint, I don't think there's been any demonstrated efficacy. And in fact, I think the use of immunoglobulins in post-streptococcal disorders, other than in Sydenham's chorea, but in the tick-related disorders like PANS or what was called PANDAS, I really don't think that there's any evidence that IVIG was effective. The second question was, one was IVIG and the other was?
CBD oil.
Cannabidiol en Tourette.
I don't have any objective experience. I certainly have we certainly have patients that have tried it, but it's really hard to tell whether it helps them or not. My general feeling at this point is if they think it helps and it slows their tics, I don't have any objections to them using it. I have not been prescribing it for them per se. Stephanie, any thoughts on that?
Yeah, I agree. I think from a CBD oil standpoint, again, we are not prescribing it. If the patients are using it, it usually means that they have gone out and have sought this on their own. And so depending on the dosing, people are using blogs to be able to help determine how much they should give. And so there's really no kind of standardized dosing across the different types of CBD oil that people are purchasing. And, it is an expensive supplement to have to buy yourself. And so I'm not sure whether or not it really helps or if it's because the cost of it is a little bit high, of whether or not there's a little bit of extra kind of buy-in from the family because they know financially that it's a little bit more expensive than what they may be getting, if they had a prescription that was approved and paid for through their insurance or something.
Ok, perfecto. Hay varias preguntas de uso de la toxina botulínica. ¿Para qué trastorno de movimiento puede ser?
So from a movement disorder standpoint, botulinum toxin, the biggest indications are going to be spasticity as well as dystonia. It can be used for either one. There's several different types of botulinum toxin. The most common being Botox. I think it was in 2017, Dysport is another one that actually became approved in the pediatric population for spasticity. And then there's other ones called Xeomin and Myablock. In terms of the use of them, a lot of times we use it more for improvement, kind of more at a focal level. So for instance, if somebody had spastic hemiplegia, spastic hemiplegic cerebral palsy, for instance, if they had spasticity in their gastroc and soleus, but maybe not anywhere else that's significant, then sometimes you could just localize your treatment just to particular muscles in the calf without having to do something else, such as like baclofen or something similar to that from a muscle relaxant standpoint. Same thing for dystonia, especially if it's focal initially, that you can kind of target it based on the symptoms and kind of the location that it is. Most of the time, you're not going to be doing Botox to a large group of muscles, just because in terms of dosing of the medication and making sure that you're putting an effective dose in the muscles that you're trying to target. If you try and spread the medication too thin, then you usually don't get a very good effect.
Ok. La doctora Herrera de Ciudad de México pregunta si en su experiencia han visto que es frecuente que una distonía se autolimite.
Yes, so it depends on the underlying nature of the dystonia. Most genetic dystonias are progressive in nature and will worsen over time. But many of the genetic dystonias also have what's called variable penetrance. So the same gene load, the same genetic disorder in different family members can have different symptomatology. DYT1 is a good example. We've seen families where you have a grandfather that has writer's cramp, a father that has no symptoms at all, and then a child that has rapidly progressive severe generalized dystonia. And that's not an unusual story to hear. There are some dystonias that do stay focal or seem to slow their spread over time. And for some of the generalized dystonias, if they get through adolescence and into early adulthood, the progression seems to slow significantly. The acquired dystonias are more likely to be non-progressive. So the dystonia is secondary to a structural lesion from a brain injury or from cerebral palsy. The one caveat to that is kernicterus, although it's a non-progressive lesion, does seem to have a dystonia that can progress and worsen over time, at least for a while.
Ok. Otra pregunta del doctor Sánchez de San Salvador es, ¿cuándo deciden tratar los tics?
So my usual criteria for treating tics are if it's causing pain, if other people and or peers are picking on them, or if it's affecting their daily activity. So for instance, if a kid had a lot of eye blinking tics, for instance, and they were interested in playing sports, that we were worried, they'd like to play baseball, we're worried that either when the ball's coming flying at them, that they're blinking so much, they're not going to be able to get their glove up to actually protect themselves, or if they'd like to ride the bike. And we were worried that they were going to, run into something, or sometimes if it's causing a lot of pain, if they have tics in which there's, jerking of the neck or neck pulling, sometimes they'll get some soreness of their neck. And so those types of cases would be when we would usually consider doing medication, but usually being very, very up to families that a lot of times this medication is not going to completely make the tics go away. It may decrease them a little bit, but you also have to remember that there are going to be certain things that are going to exacerbate the tics. So if you had somebody who had a lot of anxiety and they were getting stressed out about certain things, if you don't alleviate and improve that anxiety or remove the stressors that were actually exacerbating the tics, then you could treat the tics all that you want with all kinds of medications. But if you're not addressing the anxiety, then the tics aren't going to necessarily get better.
Tenemos varias preguntas acerca de el mejor tratamiento para la parálisis cerebral distónica.
So that is one of the most challenging issues that we're facing. Let me begin by pointing out that while we are doing DBS for dystonic cerebral palsy, that is really an off-label usage. It's really not a primary genetic dystonia. Although we know it benefits some children, it's certainly not as dramatic as we see in the primary genetic dystonias. Dystonia, the problem with dystonia in cerebral palsy is that it's only one component of the movement disorder. It's really rare to see pure dystonic cerebral palsy without other movements. Most of the time it's superimposed on spasticity, and often associated with hypotonia of the trunk, which is the real problem. Medications are modestly effective. There was a recent review through the American Academy of Cerebral Palsy and Developmental Medicine, where they actually have a pathway. And the only medication that's actually been shown to be at all efficacious is trihexyphenidyl, which unfortunately is limited in dosing by side effects. The only other thing that has actually been shown to be beneficial for use other than botulinum toxin is baclofen pumps. Intrathecal baclofen works if you don't have too much truncal hypotonia to deal with, because that becomes a problem. And it has the benefit of working on both spasticity and dystonia. And there's certainly some evidence that deep brain stimulation can be helpful in selected patients with dystonic CP, and that's an area that we are actively interested in and actively pursuing. There'll be tell them to keep their eyes open. There'll be an upcoming book from a conference in that was just sponsored by Gillette Healthcare System that should be coming out in the next month or so, that really goes over the issues of managing particularly gait disorders and cerebral palsy.
Ok, vamos a preguntar la última pregunta. El doctor Malagón de Aguascalientes pregunta si hay respuestas similares entre la estimulación cerebral profunda y la estimulación magnética transcraneal.
Yes, they're actually very different. So deep brain stimulation, you actually are going to permanently implant electrodes that are then going to be given a particular setting of whatever you program it with. Whereas transcranial magnetic stimulation is usually a little bit more temporary, in terms of you come in for a treatment, they put kind of things over your head to help from a sensor standpoint. Then they usually will do a session of stimulation, and then that's finished. And then, you know, you'll come back and do another session. We've used transcranial magnetic stimulation to help with localization, sometimes from a motor mapping standpoint, whether or not it's trying to figure out from a epilepsy surgery standpoint, localization of important kind of structures within the brain, or sometimes trying to determine whether or not, prior to deep brain stimulation, if a patient that has unilateral symptoms, whether or not they have moved some of their kind of their functions to the opposite side, or if it remains on the ipsilateral side. But in terms of, there's a lot of kind of stuff going on from a stroke rehab standpoint, as well as in the psychiatry world for transcranial magnetic stimulation. But in terms of how it works and the kind of the setup for it are different. And Dr. Marks, I don't know if you have anything else to kind of add to that at all.
The penetration of TCMS is fairly shallow, so it works better on spasticity than dystonia, because you can reach the cortical spinal tracts at the level of the cortex. The problem is that the basal ganglia pathways are really too deep to reach by using TCMS. It just doesn't penetrate that far. The effects have all been temporary with TCMS, as Dr. Acord said. So you do have to undergo repeated sessions, and it's not completely clear how much holdover you get. It has been used is being investigated in stroke rehab, to augment other things, but it's still not clear whether it's really a long-term. It does have the advantage of being very non-invasive, but it's not so non-invasive if you have to come in every week for months on end. Where it has had holdover effect is in refractory depression, and it works probably in a similar fashion to ECT, but it's much less invasive.
Ok. Pues tristemente se acabó el tiempo. Agradezco de nuevo muchísimo al doctor Marks y a la doctora Acord por estar aquí a estas horas de la noche. Le agradezco a todos ustedes por estar aquí con nosotros. Si tienen cualquier duda de estos procedimientos y de cómo los maneja el hospital, nuestra página web es cookchildrens.org y ahí podrán ver también los trabajos de investigación de los doctores. Gracias de nuevo y los dejo con el doctor Benavides para unas últimas palabras. Buenas noches.
Hola, ¿qué tal? Muy buenas noches. Agradezco la participación, en especial a las personas a los doctores que nos siguieron desde Bolivia, Colombia, Ecuador, El Salvador, Estados Unidos, Guatemala, México y Perú. Thank you very much, doctor, for your valuable participation. It was a very interesting topic. The Mexican Society of Pediatric Neurology gives you a digital certification for your lecture. Dr. Warren, Dr. Stephanie, Dra. Martina, I hope to see you in person soon. Thank you very much and good night. Buenas noches a todos y gracias por su participación.